Hello, hi everyone. The topic of today's lecture is single complete dentures. Moving on to the learning outcome, you should be able to define what a single complete denture is. You should be able to describe the various problems and complications associated with single complete dentures. You should be able to devise a treatment plan for treatment for single edentulous arches. Explain the various methods that could be used to achieve balance. So, single complete denture is a denture that occludes against some or most of the natural teeth of the opposing dentition, or a fixed restoration, or a previously constructed removal partial denture. So, according to Diwan, the perpetual preservation of what remains is more important rather than meticulous replacement of what that has been lost. Okay, so the various objectives of single complete denture are that first you should be able to establish the correct interocclusal distance, because most often, because of the many teeth missing in the opposing arch and because of complete loss of teeth in one arch, there is inevitably some loss of vertical dimension. You should be able. The second objective is to create bilateral posterior stable contacts. The third objective is to avoid any adverse tooth contacts such as deep bites and cross bite as such. And we should construct or the teeth or the denture in such a way that we are able to establish or direct the forces along the long axis of the denture. This is very important. Now, the three critical things in any complete denture, even in single complete dentures, is first, as I mentioned, was the preservation of whatever is remaining. Second is retention, stability, and so moving on. The principal challenge in designing a single complete denture is designing the occlusion with bilateral balanced occlusion, because when opposing dentition is a cast partial denture or a removed partial denture or natural dentition, there is invariably discrepancy in the occlusal plane. That is, the occlusal plane is not straight as you can imagine in the upper and lower complete denture situation. So here, depending on the existing occlusal plane, you have to achieve balanced occlusion, or you have to modify the opposing occlusal planes in order to be able to achieve a harmonious occlusion for the single complete. So as you can see, single complete denture is subjected to occlusal stresses, and it is also subjected to the position of the opposing natural teeth, the flexure of the denture based materials. All these things have a toll on the single complete denture. So in a normal complete denture, the forces are directed along the crest or the center of the residual alveolar ridges. But in case of single complete denture, first of all, the occlusal plane is not straight; it is severely canted, as you can see over here. In most of the situations, the anteriors will be super erupted. The wisdom teeth or the posterior teeth will be usually tilted towards the mesial side, and all of this will result in occlusal discrepancy, and ultimately many times you see that single complete dentures, especially the maxillary ones, have fracture in the midline. So another concept is the that we need to take care of single denture syndrome, or the what is known as Kelly syndrome. These factors, the factors that cause single denture syndrome, are the loose or tilting denture, damaged or abused to the underlying mucosa, and the underlying residual rich resorption. These are all a part or of the Kelly's combination syndrome. So in Kelly's combination syndrome, usually, the scenario in which we can see this is when a single complete denture is opposing a natural dentition, or a removed partial denture, or an existing implant hybrid prosthesis, or a fixed FP1 type of implant prosthesis in which there is no gum porcelain, and or in case of a immediate over implant over dentures or implant fixed restorations. So when a single condenser is opposing the natural teeth, usually we encounter malpose teeth, tipping of the teeth, mesial tilting of the teeth, rotation of the teeth, supraeruption of the teeth. So this becomes really challenging when we are making an opposing single complete denture, because this type of occlusal scheme is very difficult to adapt with artificial teeth. And this in turn will result in imbalance of the denture, resulting in soreness and abuse of the underlying mucosa, and will result in excessive ridge absorption in the anterior maxilla, and the denture frequently tends to get displaced, resulting in loss of retention. So all these are factors that we encounter with single complete dentures that need to be taken care of as much as possible beforehand. So now moving on when only one arch is edentulous, the tooth position in the dentate arch may preclude occlusal biomechanics being reached. Unfavorable force distribution may cause adverse tissue changes I just discussed. These changes are include extensive morphological changes in the denture can result in arch relationship and occlusal plane discrepancies. Excessively displaceable denture bearing tissues are also another problem due to rigidity. So when we are making a maxillary complete denture, we can see here that there is shunting type of forces due to result in the resorption of the anterior maxilla, resulting in inflammatory papillary hyperplasia, epilis fissuratum, and suppression of the lower anterior teeth. So most common error in making a complete denture opposing a natural teeth is the development of the occlusal scheme. So here in such cases we need to first modify the occlusal scheme, then only a successful maxillary complete denture will be made. Okay. The basically the steps for complete denture fabrication are the same. We fabricate occlusal rim, we perform orientation, Facebook transfer, horizontal and vertical jaw relationships are done. The teeth are arranged according to the opposing occlusal plane, or the opposing occlusal plane needs to be corrected first before the arrangement. So, in case of a mandibular denture, there is a smaller basal seat area. There is therefore more stress is exerted on the residual ridges, and also the residual ridges are thin knife edge, so they cannot take so much stress as the opposing maxillary ridges. Now, single complete denture, when it opposes fixed restoration, in that such cases, uh, the restored arch is considered as a natural teeth. So, for making a maxillary complete denture and lower, you have placed fixed crowns or bridges. So, in that such cases, the opposing dentition is considered as a restored arch or a natural dentition, and the opposing arch in which we are making the denture is considered as a edentulous arch. So first of all, we have to make the occlusal scheme of the fixed partial denture in such a way that it harmonizes with the various balancing curves like curve of Spee, curve of Wilson, curve of Mulsoon, Pleasure's curve, etc. Okay. Then there are situations where you have single complete denture opposing an existing complete denture. Okay. Then we have single complete dentures opposing removable partial dentures. So completely edentulous maxilla and partially edentulous mandible with only anterior teeth remaining is the most common situation. That is, in the lower arch we have Kennedy's class 1 situation, and upper is a completely edentulous arch. This is the most common situation, and perhaps this is why Kelly's combination syndrome is also seen almost exclusively in this type of scenario. So we can see degenerative edentulous changes in the anterior or the premaxilla. There is elongation of the tuberosities. There is rich resorption in the posterior edentulous mandible. So all these need to be solved before a successful maxillary complete denture and the mandibular RPD is fabricated for such patients. We can also extract all the remaining lower teeth and fabricate upper and lower complete dentures, but this is not desirable for the patient. Patient wants to retain as much as teeth as possible, because this will aid in retention, and they have a certain amount of emotional attachment also. So, what are the various problems or complications that we see in single complete dentures, and how we solve them? So, as I mentioned, there's occlusal disharmony, suppression of the anterior teeth, discrepancy of the occlusal. So, depending on various scenarios, patients are divided into various classes. Class 1 is a patient who has only minor occlusal discrepancy, which can be corrected by minor coronoplasty. Class 2 is a patient who requires some addition to the existing uh, teeth, that is in the opposing arch where the teeth are there. In order to achieve balance occlusion, you need to add on some restoration on top of the teeth surfaces due to severe attrition or erosion. These are class 2 patients. Class 3 patient is patients who require some amount of enamel grinding or enameloplasty, and some team they required some addition of the or coverage of the cuspal areas due to the severe erosion and attrition. Then class 4 are patients who present with occlusal discrepancy that require addition to the width of the occlusal surfaces. That is, the lower teeth or the opposing dentition natural teeth needs to be, the occlusal table is very narrow. You need to widen the table before fabrication of the denture in the opposing arch. So these are class 4 patients, and class 5 patients are patients who present with Kelly's combination syndrome. So when we fabricate denture teeth, like we are fabricating a single complete denture for the upper arch, we first need to correct the occlusal discrepancy in the opposing mandibular arch. Okay, so there are various techniques for correcting occlusal discrepancies that have been advocated over the decades by Swenson, Eustace, Bruce, Boucher, and so Swenson's technique is basically we do the jaw relation, mount the maximomandibular cast at the acceptable vertical dimension. Then the denture base is made and the denture teeth are set. If any interferences are there, we just mark them with a pencil on the natural teeth, that is the mandibular teeth, and then the dentist uses these markings on the lower teeth as a reference, and then adjusts these in the opposing dentition. Next is the Yogstars technique, in which we use a metal U-shaped template. We have occlusal template which corresponds to the curve of Spee and the curve of Wilson and curve of Monsoon. So basically this is a template which is made or a part of made from a sphere which has a 6-inch radius, because as you would recall, the curve of Spee is from the center of the glabella to a dimension or radius of 6 inches. Using this occlusal template that is kept on the opposing direction, that is here the lower teeth, and any teeth or cusps which are above the occlusal plane are then ground off. Okay, so see here we can see the wisdom teeth distobuccal cusp is superior to the occlusal plane. Here the first molar lingual cusps are above the occlusal plane, so these will need to be adjusted so that the occlusal discrepancy can be removed. So this is Yogsta's technique, in which you use occlusal template which corresponds to a 6-inch sphere in curvature. Okay, next is the bruise technique. In this technique, we see any high cusp or sharp cusp or any occlusal discrepancy. These are then ground off from the opposing dentition. Then a clear template using a vacuum form template or a clear acrylic resin is fabricated, and using this template the dentist places this template in the patient's mouth and grinds the any interfering areas or areas which have been which are above the occlusal plane, and he keeps doing it until this template seats completely. And after this the teeth setting is done, or if teeth setting has already been done, the teeth setting is modified so that we can have a proper bilateral balanced contacts. Okay, so this is technique. So you can see here these are all the areas that need to be modified. They have been ground or trimmed on the master cast. Then template, clear acrylic resin template has been fabricated. Okay, and then this template is then used in the patient's mouth to grind these areas. So all these areas which are marked and scraped on the cast are then scraped using this template in the patient's mouth till the template sits firmly in the patient's mouth. And after this, the posing, that is in the for the maxillary complete nature teeth setting is okay. So next is the Boucher's technique. In the Boucher's technique, basically is pretty simple. The casts are mounted on a programmable articulator. The artificial teeth are arranged for the best possible balancing contacts. Okay. So if the natural teeth prevent the balancing contact, interferences are removed by moving the porcelain teeth over the mandibular stone teeth. Okay, so in this case this is only possible if we have porcelain teeth, and on the articulator itself the function movements are made so that the porcelain denture teeth will grind or cause attrition of the opposing stone teeth, and then this denture is then processed and is placed in the patient's mouth, and accordingly the that is at the denture insertion appointment, the natural opposing teeth are then ground off till we have a proper bilateral balanced occlusion in the patient's mouth as well. Okay, so basically all of this technique has some amount of arbitrariness involved, so it's not perfect. You have to keep doing it. It's like trial and error technique, but the main idea is to remove any gross occlusal discrepancies, and if any teeth are severely super erupted, those teeth should be. This is another technique, Broderick's flat technique. Again, this technique follows the curve of Spee. So here first on the canine you place the canine tip, you place a compass, you attach a flag or a graph paper on the articulator, you mark a curve, then you place the compass on the mesobuccal cusp of the first molar, then you draw another curve. So this is the center of rotation of your arc, and then using a carbon marker in the compass, you then mark a line on the opposing teeth, on the opposing dentition. this way, using this center as the center of the arc U, and at the fixed width of the compass that we used before, we will draw a line. So any teeth that are above or below this line are then ground, that is natural teeth. The enamel plasty is done first on the cast and then on the inside the patient. Okay, so there are various now this was, we were talking about the various techniques to remove, correct the occlusal plane, that is to remove occlusal disharmony. Now as we'll talk about techniques to achieve bilateral balanced occlusion. That is, there are basically two techniques: functional chewing technique and articulator equilibration. Basically, in functional chewing technique, this was advocated by various authors like Stansbury, Wake, Shari, and so this is not a very difficult technique. So basically, all four have advocated the same thing. That is, patient is made to do functional or chewing or grinding movements in his mouth before the teeth arrangement is done. So in Stansbury used compound trim. That is, here we have the anterior teeth are first arranged according to the midline, the aesthetics in the occlusal plane and lip fillers, and then in the posterior tooth area compound trims are made, and these compound trims were then slightly trimmed in height and width, and then on these compound trims, carding bags, the same bags which is used by the manufacturer to hold the teeth in their boxes or in their casing. The set carding wax is applied onto the compound on the buccal and lingual and occlusal side, and the patient is made to do functional movements for 10 to 15 minutes. So then we get this ground appearance on the occlusal surface, and this is then beading and boxing is done, and then a stone template is poured onto this. So you will get a stone index of the occlusal surface over here. As you can see, this is the stone index of the occlusal surface. Now the mandibular cast is removed, and this stone index is placed opposing the maxillary denture, and the teeth arrangement is done based on the stone index. We call uh, wax was added or compound was added, and the patient was asked to do various functional movements. These are various techniques that were advocated by these authors. Basically, functional chewing technique or functionally generated pathway. Next is the articulator equilibration method. So this technique says that any functional chewing done in the patient's mouth will not be accurate because the denture bases are not stable. So they'll have some amount of movement and shaking inside the patient's mouth due to the resiliency of the oral mucosa. So it's always better to do an equilibration on the articulator itself. So the articulator, in the articulator technique, after the denture have been processed, they are remounted onto the articulator, and the balancing occlusion is re-verified on the articulator itself, and the occlusal surfaces are modified till we get a bilateral balanced occlusion. Okay, so that brings us to the end of the complete dentures. Now, briefly to talk about Kelly's combination syndrome. When we see this corrected, if there is mandibular teeth are super erupted first, the occlusal plane needs to be corrected. Thing is, we have to always fabricate a maxillary complete denture opposing a mandibular removal partial denture. If we just have mandibular lower anterior teeth and we don't have posterior teeth in the mandible, then it will frequently result in fracture. We can also reinforce the denture like polyethylene fibers, polyaramide fibers, glass fibers, carbon fibers. These all can be used as a reinforcing material inside the denture base material. Wear and its management. So some amount of occlusal wear of the denture teeth is expected due to the it opposing a natural dentition or a fixed partial denture or ceramic dentition. So some amount of artificial tooth wear is inevitable. Only thing is, by in using high impact denture based resin and using high quality denture teeth like IPPT, IPT, interpenetrating polymer network teeth, IPTN teeth, we can reduce this amount of attrition of the denture teeth. And as I mentioned, patient has to be responsible about his diet, and proper balance occlusion needs to be given in such cases, so that way we can avoid denture teeth wear. Different type of teeth that have been used over the years are the acrylic teeth, the porcelain teeth, the gold occlusal surfaces, and the acrylic teeth with a cobalt chromium occlusal surfaces. These all have been tried over the years Porcelain teeth are no longer used because of their attrition or abrasion of the opposing teeth, and due to clicking of sounds that is produced by porcelain teeth, and also due to the frequent debonding of the porcelain teeth from the acrylic resin. Gold occlusal surfaces, they are poor aesthetics, they are time consuming and expensive, so they are not used. Acrylic teeth are the most versatile teeth that are being used. Also, high impact acrylic resin teeth and interpenetrating polymer network teeth (IPPTN) teeth are also used nowadays by most reputed manufacturers to prevent the wear of the denture teeth. Okay, this is what I was talking about. IP and interpenetrating polymer network (IPPN) teeth have they are highly cross-linked interpenetrating polymer network. Okay, so most of the ivocular teeth are the IPN teeth. So this is, even some authors have tried to use amalgam fillings on the occlusal surfaces. That is, class 1 fillings were made on the occlusal surface of the denture, and these were then filled with amalgam, all in an effort to reduce the wear of the denture teeth. But this always occlusal wear is an ongoing process, and it keeps happening. And basically, these things, these techniques haven't caught on much. Not many people use these. Okay, we can even use onlays, just like amalgam, onlays of gold or palladium, etc. So then we have the advances we have already talked about. CAD cam and CAD cam designing, how it has revolutionized the fabrication of implant dentures, and in cases of oral rehabilitation also we can use CAD cam for designing a digital or CAD cam milled complete denture. Okay, so this is how a denture base is first milled, and the teeth mold of which we had selected from the denture library are then attached with a resin luting cement onto the denture base. So basically the whole denture is not milled, the teeth are milled separately, the denture base is milled separately using the CAD CAM milling unit, and then the teeth and the denture base are then added or glued together using resin cement or the flowable resin. Okay, so that brings us to the end of this lecture. This is the reading list of various books that need to be read. I always stress that please have standard textbooks like Boucher's, Hartwell. Okay, so these textbooks are really important for not only single complaint dentures, for all topics in removable prosthodontics.